morning, everybody, and welcome all of you to live program number 133 at Orthopaedic Principles. We are back with our fantastic faculty, Dr. Pradeep from Mumbai. Dr. Moonot completed his fellowship in trauma and orthopedics in the UK, and he worked as a consultant for a very long time before coming back to Mumbai. Today, he's going to enlighten us about Hallux Rigidus. So today, it's my honor to bring back Pradeep Moonot for this fantastic lecture. Over to you, Pradeep.
Thank you very much, Hitesh, for inviting me once again on your channel on Orthopaedic Principles. And I hope the previous one has gone well, and we'll talk about Hallux Rigidus. So without wasting much time, let's talk about the history. It's a very, very long history for this condition. It was described first in 1887 by Davis Coley, and he called it as hallux flexus. And after that, there have been various terminologies given to the same condition. Cottrell coined the term hallux rigidus, and Duvres in 1959 and Moberg were the one who actually described this condition, which was the most common condition to affect the first MTP joint, described as hallux rigidus. If you look in the literature, even till date now, I was reading through the literature for preparation of this presentation. People still using hallux limitus, bunions, dorsal bunions, hallux malleus, or metatarsal primus elevatus. So these are the different terminologies which are still commonly used for hallux rigidus, and you just have to be aware of it when you are searching, especially the literature. So what is hallux rigidus? People probably don't know, or probably in the early stages of their orthopedic career. It is basically a painful condition of the great toe involving the metatarsophalangeal joint. And it is characterized by various things. There is a restriction of motion, and the motion which is restricted is mainly the dorsiflexion which gets restricted. That is because of a starting of a dorsal osteophyte which is there. Also, there is a proliferative periarticular bone formation which is seen around the MTP joint. So this is what you can see on the X-rays here is a large dorsal osteophyte, and you have to be very careful, and you have to speak to your radiographer to get a very nice shoot-through lateral view. On the clinical examination, I'll come to what you see in the clinical examination, but many times you will see that you feel the tenderness at the MTP joint. You can feel the bump or the dorsal osteophyte present. So what is the etiology? So etiology is a common described etiology is trauma, and that could be a single episode of a high energy trauma or an intra-articular fracture or a crush fracture which involves the articular surface can give rise to hallux rigidus. While common conditions which we normally see in a day-to-day practice for patients coming with hallux rigidus is repetitive microtrauma, where there is either a forced hyperextension or a plantar flexion injuries, or because of a twisting injury, you have a chondral or osteochondral injury. And this is on a repetitive basis over a long period of time can give rise to mild arthritis in the joint leading to hallux rigidus. So what are the symptoms? So in the initial stage, patient comes with pain. They come with pain, they may have a mild swelling, and this swelling is initially because of the synovitis which is present in the metatarsophalangeal joint, which are leading to the inflammatory response and causing the symptoms. While in the late stage, you get a plethora of things which are happening into the joint, which leads to the symptoms. And these are the plethora of pathoanatomy which is there, which is usually a dorsal and a dorsolateral exostosis which is present. There is a bony ledge, there is an increased bulk around the joint, the constructing footwear, a dorsal exostosis enlargement is there, which also leads to problem in wearing the shoes, especially people who are wearing a narrow bellies. They complain of a lot of pain because of irritation of the top of the footwear. These give rise to pain and swelling. And finally, because of these exostosis or because of the dorsal osteophyte, there is limitation of dorsiflexion and pain as well. So as I said, what are the signs? When you're seeing these patients complain of swelling around the MTP joint. Okay, this is where you can see here clearly, and that is because of either initial synovitis or later on because of the osteophytes. Now, if the patient has these symptoms for a prolonged period of time, then what happens is because of the first ray pain in the first ray, they try to offload that area and they started walking with a inverted gait. So inverted gait, sorry, inverted gait. We're trying to offload this area and the patient starts walking more on the lateral border of the foot. And because of that, they get these callosities over the lateral part of the heel and the lateral part of the foot because of the gait changes as well. Also, because of the dorsal osteophytes present, the one of the nerves which is supplying the great toe, that can get stretched, and you have to be careful, or you have to be very uh, careful in your examination to check for sensation both on the medial side and the lateral side of the great toe, and to document that there is a change in the sensation, because if you have a surgery and the patient then complains of loss of sensation, you can be in a soup as well. And of course, you check for the range of movement of the great toe, how much dorsiflexion and how much plantar flexion you have. Always document the range of movement because that also helps in the planning of the surgery. Also, what you would want to see is any other general examination of your foot, any forefoot pathology, always check for any deformities if the patient has a pes cavus or a pes planus, along with this signs and symptoms. And along with this, always check for gastrosoleus tightness. So you always do a Silver's coil test, and I'm sure you know how to do a Silver's coil test, where you check for dorsiflexion of the ankle with the knee in flexion and knee in extension. And if there is a difference of around 10 to 15 degrees, that means there is a gastroc tightness. And if you're treating these patients, then you need to make sure that you either send the patients for the physiotherapy, plus minus if you're doing surgery, you may need to do a gastroc resection. So the first primus investigation you would ask for in these patients is a radiographic evaluation in terms of x-rays, and always make sure you get a weight-bearing x-rays for these patients. So in the initial stages, you find there is a non-uniform joint space narrowing. There may be slight widening or a flattening of the first metatarsal head. Well, if you look in the advanced stages, you can see all the signs of arthritic changes, which you would see in a joint where there is a subchondral cyst present. You have sclerosis present of the metatarsal head. There is widening of the base of the proximal phalanx because of the erosion as well. There is hypertrophy of the sesamoids. And what you need to also do is then you check for any changes which are present in the lesser metatarsals as well, because of decreased loading of the first ray, which can ultimately lead to changes in the lesser metatarsals. So what are the classification? All the patients in orthopedics, we know that we like to grade these patients into a different classification. So you have a classification for Hallux Rigidus as well. When grade 0, there is no changes on the X-ray. There is a mild pain and mild stiffness present of the grade toe. There is a loss of passive motion. But in your range of movement, when you actively check, there is a good amount of dorsiflexion of almost up to 60 degrees present. And radiographs are almost pretty much normal. If you look at grade 1 changes, there is a pain at present. Pain is there, and especially pain is at the extremes of dorsiflexion. So at the terminal range, patient complains of pain. The range of movement is slightly reduced, so the arc is getting reduced. The dorsiflexion is only up to 40 degrees as well. And if you look at a weight-bearing X-rays, you can see on the X-ray there is a slight spurring. Here you can see there is a dorsal spur as well. There is a mild joint narrowing, and this is where a comparative X-ray of the other side. And if the other foot is normal, get the comparative X-rays of the normal side, and you can appreciate how the joint space is slightly narrowed. There is minimal periarticular sclerosis and maybe a minimal flattening of the metatarsal head can also be seen. Grade 2 changes, the symptoms are getting worse. There is slightly more pain present. The stiffness is gradually increasing. Pain especially during the range of movement of your dorsiflexion. Pain and the restriction of dorsiflexion is also there. The dorsiflexion range only up to 30 degrees as well. And you start looking at the X-rays, there is significant osteophytes present. And osteophytes, you can also look both in the AP view and also in the lateral view. There is a less than 25% dorsal space narrowing is involved. Again, you look that on your lateral X-rays as well. And mild to moderate joint narrowing and sclerosis are seen. Grade 3, where there is a constant subjective pain. So the patient is continuously complaining of pain, both at rest as well as soon as the patient starts weight bearing as well. As you look at the range of movement, the movements become more painful and the whole arc is almost painful as well. Range of movement 10 degrees of only dorsiflexion, 10 to 20 degrees is present. And in radiographs, your joint space is getting narrower and narrower. More than 25% joint space is narrowed. And dorsal and both involving the dorsal side and the plantar side as well. And if you can appreciate your sesamoid, the sesamoids are also enlarged. Grade 4, this is a worst stage where there is a continuous pain, constant pain is present. There is a significant stiffness. You can hardly get any movement. There's only a jog of movement in your great toe. There is a significant enlargement, lot of osteophytes both on the dorsal side and the medial side as well. More than 50% of the joint narrowing is present. You can see here in this X-ray, there is a complete loss of the joint space. Florid osteophytes are seen. You cannot appreciate any range of movement on your examination as well. So that's grade 4, equivalent to almost a grade 4 of the knee changes as well. And there will be deformities as well. So coming to the management, how would you manage these patients? Of course, all management, you have conservative treatment and you have a surgical treatment. And in surgical treatment, there are lots of options. Only options of only fusion or a Keller's is not there. So you can do a cheilectomy, and I'll come to what do you mean by cheilectomy. You can do an osteotomy, and your osteotomies, you can do a metatarsal osteotomy, you can do a phalangeal osteotomy, and of course, as any arthritic changes you can see, you can always do arthroplasty, that means replacement, or an arthrodesis, that means a fusion. But let's come to conservative treatment. So in all our patients in early stages of the first time they present, you always need to manage these patients conservatively, even irrespective of which grade it is, grade 1 to grade 4. In early stages, you're looking at getting them painkillers and analgesics, you're giving them anti-inflammatory, reduce their swelling and the stiffness. You're of course giving them ice. You're telling them if there's an increase in the activity, rest. And especially the key thing is I advise to all my patients, these are the patients where they really need to go in flat footwear. They cannot be wearing any sole or any heels because that would really give that dorsiflexion, kick in the dorsiflexion, and that would give them pain as well. So here, definitely these patients really need to avoid heels. And of course, along with this, you need to send them for physiotherapy for gentle range of movement exercises. And as I said before, if they have any other pathology or any deformity in the foot, that needs to get corrected as well. If the gastroc or the gastrosoleus is tight, that really needs to be looked at, and stretching of the gastrosoleus is very important. Once you've gone through your conservative treatment and the patient still complains of pain, then the next option you have is an intra-articular injection. And I definitely try in patient, especially in the early grades. So like definitely in grade 1, 2, and 3, I would definitely advise these patients, if they have gone through these treatment options, then to go for an intra-articular injection. Because in grade 1 and grade 2, there is a fantastic results. You can at least get up to 6 months of a pain-free range of movement. And during that time, they can look at other conservative treatment and physiotherapy. And always you can repeat this injection, say every 6 months to a year. In my practice, I always tell these patients, I give them at least 2 to 3 injections over a period of time. And usually these patients behave in a method of reducing efficacy, where by the second or the third injection, the efficacy of the steroid injection reduces. They only get benefit for 2 3 months, and by that time they are mentally prepared as well that some surgical form of treatment may be required. So intra-articular steroid injection definitely works and should be given options as well. Also, the other thing in your conservative treatment is getting them a stiff insole. So here you can see clearly, you can advise this patient, you get a stiff sole made customized. And what I do nowadays for my patients, I give them a very thin carbon reinforced insole, which prevents excessive range of movement of the great toe, and thereby reducing the inflammation, reducing the synovial irritation, which really helps in giving them good pain relief. And these patients really like them, but you can either give them off-the-shelf insoles, and off-the-shelf carbon reinforced insoles are also available, or you can get them made or customized for the patients. Now, if you have gone through the conservative treatment, and if the patients are still painful, then what are the surgical options you can look at? So this is my algorithm which I made for all the different parts of grades. So grade 1, as I said, is a mild degenerative disease. If there is a decrease in the dorsiflexion and no exostosis, you can offer them a phalangeal osteotomy, and we will come to how it helps. If there is a decrease in the dorsiflexion and if there is a dorsal osteophytes present, then you can offer them a cheilectomy. And if there is a hypermobile first ray, then you can get them again a plantar flexion osteotomy. And I'll come to it how these different types of surgical interventions help. In grade 2, moderate degenerative disease, decrease in the dorsiflexion and a dorsal exostosis, a cheilectomy, and decrease in the dorsiflexion and dorsal exostosis, again, you could offer them a cheilectomy or a phalangeal osteotomy. So depending on what are the conditions you find on your x-rays and different findings, you can offer either a cheilectomy or a cheilectomy and phalangeal osteotomy. Grade 3 and 4, these are the severe forms of Hallux Rigidus. You can offer them joint sparing operations like a cheilectomy, and especially if you are looking to save the joint, or the joint is involvement is less than 50%. So more than 50% joint surface is viable. Then there's an array of things which you can offer to these patients. You can give them fusions. You can do a killers where it's a arthroplasty, excision arthroplasty, a soft tissue interposition arthroplasty, or an implant arthroplasty. So let's look at a proximal phalangeal osteotomy. So what we said is patients who have early degenerative arthritis and do not have an exostosis. So what you can do is a functional transfer of a plantar flexion to a dorsiflexion. So in these patients, if the dorsiflexion is restricted, what you're doing is a dorsal beige wedge, you're taking it out, and you're effectively changing a range of movement of these patients. So you are changing your plantar flexion into a dorsiflexion. Okay, so you could do a dorsiflexion, dorsal wedge, or you can do a cheilectomy. You can take out the dorsal osteophyte, do a dorsal beige, close it, and either fix it with a screw or a K-wire, and these patients do well. And the indication for these patients are mainly in adolescent patients, early age group of people with no significant osteophyte formation seen. So what is cheilectomy? We talked about cheilectomy in most of the different grades of degenerative disease or Hallux rigidus. It's basically an excision of the dorsal osteophytes of the metatarsal head. And here you can clearly see there's a large osteophyte here, which has been taken away. And the key thing in cheilectomy is you effectively not just taking the osteophyte, you are starting and you are taking you start from the articular surface of the joint and you come out on the dorsal aspect. So in the initial stage, when you start doing this, you will really say, oh my God, am I going to enter into the joint? Am I taking a normal cartilage? Yes, you do need to get into the joint. You are almost taking a dorsal 1/4 to 1/3 of the dorsal aspect of the articular surface. And that is the reason they are successful. And one of the commonest cause of a failure of a cheilectomy is because you're not taking it enough. Otherwise, they are still stiff and they do not get the best outcome from these surgeries. So indications, grade 1 and 2 patients, younger patient, athletic, or in advanced arthritis. So you can go up to grade 3 as well, as long as patients are made aware of the limitations of the surgery. It's a proper consent taken and the informed consent. Then yes, you can go ahead and do it. As I said before, it leaves a stable joint, it has a low morbidity, and you can still have a flexible joint. Of course, the downside is if there is a more than 50% arthritis and trying to do that, the patient can still complain of pain and you can have a failure of the procedure. But the key thing, as I said, the failure of cheilectomy is not taking that dorsal bump enough. So excisional arthroplasty, where you take off the medial aspect of the head and the proximal phalanx. It was done in the past in a lot of patients, especially in rheumatoid arthritis and advanced degenerative arthritis. It is a fantastic pain relief operation, but it leaves the first day which is slightly unstable. It is good for patients who are elderly, who want a quick fix and who want to mobilize them quickly. So that's why in younger patients who want that first ray to be stable, who want a good push off, these patients, especially excisional arthroplasty, is not a good option because it leaves with a flaccid, non-functional first ray and you can have a floppy toe. So I would not advise for young patients. But elderly patients whom you want good pain relief and you want them to go quickly up and about on their feet, this is a very good option. You can also do a soft tissue interposition arthroplasty. I have not done this. This is from the literature where you can take off the head, a little bit of head. You can take off the proximal phalanx, base of proximal phalanx, and then you wrap around a fascia between the joints, or you can take one of the tendons, the flexor or the extensors, and you put it into the joint. Especially these are good for in grade 3 and grade 4 rigidus. If you have a very short first metatarsal, and I will come to one of the cases, you should not be doing this because you're going to further shorten the first ray and that would lead to overloading on the lateral aspect or the lesser metatarsal, leading to a metatarsalgia. So I would not recommend in these patients. But yes, this is an option if nothing else works. First metatarsal osteotomy, as I said before, if you have a hypermobile ray or if you have a long ray, then and you have an early degenerative arthritis, you can do the osteotomies where you can shorten the first ray. You can take a dorsal wedge osteotomy and you can, again, along with it, you can change the arc of motion and get a better articular surface to articulate with the proximal phalanx. So grade 1 hypermobile first ray, and the types you can do a variable types of osteotomies. You can do, as I said, a dorsal wedge osteotomy. You can do a plantar flexion closing wedge osteotomy like a big vials, which you do on your lesser metatarsal. You can do that way as well, or you can purely do a shortening osteotomy. However, be aware you really need to know your biomechanics and pathoanatomy properly because these are unpredictable. So you have to be sure enough that the first metatarsal is long, it is overloading, and you need to change the arc and accordingly deal with it because otherwise you may end up with instability and not giving any predictive improvement in your symptoms to these patients. So coming to the gold standard for Hallux Rigidus is Metatarsophalangeal or MTP Arthrodesis. The indications are Hallux Rigidus, so grade 3 or grade 4, severe degenerative changes. In these kind of patients, you could offer them arthrodesis or a fusion where all the previous conservative treatment and the injections have failed. Okay, so I would just swap my lecture and go to the other one. I'm just going to stop share and again start sharing because I think you can start recording. I think the recording.
Yes, go ahead, please.
Yeah, so the reason I am specifically talking about an MTP fusion is because I think it's a very, very important surgical armamentarium or a surgical technique, and everybody should know this, should be very familiar with this, and it's a very important topic because you can use in a variety of cases. So I just started with a case of a 67-year-old lady, pain in the forefoot, difficulty in walking, severe deformities, not able to get in. So these are the kind of deformities I see in my practice routinely. And yes, you could try to save the joint, but this lady wanted a single surgery. You don't want to come back and give them any other, call them back again and again. So MTP arthrodesis, grade 4 or grade 3, Hallux Rigidus with more than 50% loss. And of course, there's an array of other things, other conditions which you can do a fusion with. However, be aware, knowing just the indications is not enough for any technique. You also need to know the contraindication. There are contraindications if you do not have a good soft tissue cover, like a scar on an ulcers or an active infection which is going on, or if patients are diabetic, which is not controlled, or if you have vascular insufficiency, you should not be doing that. Always beware patients whom you offer an MTP fusion. You need to tell them that they may not be able to wear high heels, or beware that you should be very careful in offering this surgery to patients with grade 2 and grade 3. Where if a patient has arthritic changes in the IP joint, you just need to be aware and inform the patient that the IP joint can become symptomatic and you may need to deal with that in the future. So MTP arthrodesis, the goals, as I said, is to improve the function, reduce pain and improve the mobility. And the technique is I do with a dorsal incision, just go slightly medial to the EHL, expose it, identify the EHL and retract it. Once you have done that, you're literally into the joint. Have a good exposure, okay? Because the key is you want to have a nice exposure. You can see the surfaces of the metatarsal head and the proximal phalanx, so you can prepare the joints properly. Once you have done that, there are two ways of preparation of your joint surface. Either you can take a saw and you cut the two surfaces of both the metatarsal head and the proximal phalanx with your saw, plain cuts, and that's it. Or you could do what we have these reamers which are available with different companies. You have a concave and a convex cut of the metatarsal head and the proximal phalanx. And the key difference is if you're doing your planar cuts, there is a possibility of a shortening of the first ray, but effectively it is more stable. While in a convex and a concave cuts, you need, of course, special instruments from the company. It maintains the length of the first ray, but it could be unstable because you don't know how you're placing it. And there's significant studies now which have showed that though the shortening is between 7.1 to 5.7, they're not statistically different. So as long as you're aware of that, both the techniques are fine. As I've already said, planar coaptation versus convex and concave. And the key thing is once you prepare your joint, how do you fix them? Using just K-wires is a no-no. You can use screws, you can use plates, or you can plates and screws. So let's look at that. So once you've prepared the joint, you need to fix it with, here you can see clearly, there's a one interfract screw which has gone through and then a dorsal plate which has been put. But make sure that you do make sure that on the plantar aspect, there is a ledger bone which is present, which needs to be taken out and cleaned up and get a good opposition. So looking at the fixation, you either look at K-wires, screws. Screws can be single, cross screws or parallel screws. Plates, you can have non-locking plates or a locking plates, and you can use staples as well. So let's look at some literature. In 2007, Sharma et al. Showed that a single compression screw versus compression screw and a dorsal plate on planar cuts. No significant difference in time to clinical and radiographic fusion. However, Hunt in 2011, he used locking plates versus non-locking plates. 93% results with locking and non-locking was 95%. So they concluded that there was no advantages of using locking plates. Patel et al. In 2005 used two screw versus one screw versus staples. and they found that 100% with 2 screws, 78% with 1 screws. Only using one stable is a no-no as well. So look at some cases like this. Using 2 screws is fine. You can use that. This is one of my case. I'll discuss that. You can use a plate and screws as well. So coming to this lady, severe deformities. Look at that kind of deformity which is present. And this is the post-op has been corrected with KY. So both sides I have used locking plates and screws as well. Another patient, severe deformity. So one interfracted screw and the plate. Key thing when you look at these patients, what is the position of the great toe which needs to be during your fixation? So it has to be neutral rotation. It has to be 10 to 15 degrees in valgus. It should not be too straight. It needs to be in slight 10 degrees of valgus. So when a clinical appearance, you have between, there is not significant gap between the first and the second ray. And the key thing is there should be around 10 to 15 degrees dorsiflexion compared to horizontal, or 25 degrees from the first metatarsal. Now that's too difficult, I think, clinically to judge how much you can get 25 degrees from the metatarsal. So what I would suggest is every patient when on table, I do this is called the plate test. So take that plate on the top of any trays which you have on your trolley, which you ask your sister to keep it, and you make sure you dorsiflex the ankle and you keep it touching the heel and the sole, and the great toe should be just touching it, and you should be able to slightly dorsiflex and it comes back. Okay, so that is the key thing. This is the key test, because the reason is when the patient is walking, this is the way they're going to walk. We don't know what is the angle. 15 degrees, 20 degrees, 25 degrees, 10 degrees, we can't make it out. I cannot make it out. So I always use this dorsal plate test, what I call it. And always on all my MTP fusion, I keep this tray on the back of my trolley, and during the fixation, I fix it with KYs and make sure I get this position. Another paper looking at the non-union rates, and the main configuration was compression screws, dorsal plate and screws, or staple. And this was a systematic review of 37 studies in a total of more than 2,800 joints. They got a non-union rate of 5.4%, a malunion of 6%, and a hardware removal of almost 9%. So beware when you tell your patients that there is a non-union rate of around 5% and hardware comes out in almost 9%. So quality of early union after first MTP joint. And what they found that 6 weeks post-operatively, they got a CT scan done and only 7% showed complete union and 38 or 92% showed partial union. So at 6 weeks, a mean standard deviation joint bridging was only 54%. The reason is why I'm showing this is post-operatively, we cannot allow these patients to weight bear, because when you weight bear, there is almost a significant force going through the forefoot and through the FHL as well. So, and not a single construct is able to wear this load. So rocker bottom sole specifically used to reduce the ground reactive force at the MTP joint should be used. So these patients still needs to be kept non-weight bearing till you non-weight bearing or heel weight bearing till the union happens. So that's why ankle immobilization will decrease the forces across the first MTP joint by diminishing tendon variables. So what are the complications seen after the MTP fusions? As I said, non-union is common, malalignment can also be common, and the non-union is mainly because of inadequate resection of the surfaces. So that's why key thing is joint preparation, joint preparation, joint preparation. Another case, severe hallux valgus present, crossover toes, and fusion done, and reasonable valgus present, and she went on to do very well. So how do patients perform after MTP fusion? The satisfaction rate is between 75 to 100%. And Brodsky et al. Showed there is a significant improvement in propulsive power, improved weight bearing function of the whole foot. And of course, because the first day is more stable, patients find it that the walking and gait improves significantly afterwards. Now, can we do better with newer technology? So This was one implant which came out where there was a pocket hole through the plate with fragment screws. They thought that would work better. However, they found that there was almost one third of the patients went into non-union and 6% only gave partial union. So high non-union and revision surgery. So sometimes technology kills the so newer technology is always not better. So always understand, check the literature, and then start using devices in your clinical devices. So pearls for MTP arthrodesis. The goal of the surgery is to end up with a great toe within the 1 centimeter of the overall length of the second toe. When you're preparing the surface, use cool water and make sure you prepare your joint surface quite well with small K wires to minimize the surface area and remove small portions of sclerotic bone. Make sure, I never used to use it initially, but I have now routinely starting using intraoperative fluoroscopy to make sure how my interfragment screw goes, how my plate is sitting, and I want my plate to be in an optimum position. When you're preparing the joint, make sure you're protecting the EHL because you do not want your EHL to be cut by your saw or by your reamers. Always make sure you are from the dorsal aspect, you're going right up to the plantar aspect, you're visualizing the volar plate because invariably you can leave a plantar shelf of bone which will prevent you from compression. The plate should be exactly contoured and get the best position. And there is no leeway in positioning. If you get it too dorsiflex or plantarflex, the patients will not like it. So in conclusion, the MTP fusion is a fantastic operation. No functional limitations. Patients can do everything, can do very well. Of course, you have to make them aware that wearing heels and especially high heels may not be an issue at all. So I'm going to go back into my original presentation where we had stopped it. There you go. So I think, so MTP arthrodesis. So and what are the, and we have spoken about that. What are the last option? Always any joints you can fuse them or you can replace them. So replacement again in grade 3 and 4, Hallux rigidus with severe degenerative changes, you can do it. But of course the complication is the wear and tear and the failed implant. And if you look at the history of arthroplasty, any joints, hips, knees, and including the MTP joint, they have used metal on poly, metal on metal, and ceramic, and none of them have worked. They have had initially they started with Cheilectomy, that failed. When I was in UK, we started doing the Mojo, which was a pure ceramic implant, and that would squeak like anything, and that also failed. Then you had a metal on poly, nothing has worked. And I'll give you, this is the recent paper from 2016 from Switzerland. And this is the kind of implant. So they had almost like a partly between a knee and a hip implant. And here you can see how that's been nicely put on the metatarsal head. Then you have a poly in between, and that goes in your proximal phalanx. Fantastic design and great work. They had 29 patients in 29 joints in 25 patients with an average follow-up of almost 4 years. And what did they find? They found that 25% of the patients almost underwent one or more secondary surgeries after a replacement. Almost 14 patients ultimately went to a conversion to an MTP arthrodesis. And they concluded that the MTP arthrodesis using this implant had a high amount of revision surgeries, and there was a high variability regarding this prosthesis, regarding the component alignment and poor range of movement. So patients who did well, they continued to do well, but there was no predictability how satisfied they would be, and the range of movement, improvement in the range of movement was not very good as well. So finally they abandoned it as well. So this is just one of the recent literature on MTP arthroplasty. What is the new kid in the block? Anything else you can do it or not? So this is the other one which has come out with, where it is looking at a polyethylene. So you have a small synthetic cartilage called as a hydrogel, which is implanted into the metatarsal head. So if you have an area, a loss of cartilage, a loss of cartilage in the metatarsal head, you can remed and you can put this synthetic cartilage implant into the first MTP joint, and this is called Cartiva. And there have been multiple literature and publications on this coming from Canada, UK, and a little bit in the US, but most of it is coming from Canada and UK. Mark Glazebrook is a friend, and Tim Daniels as well as Dishan. And what they have seen, so I have just picked up the most recent paper, the midterm follow-up. They had a 2-year follow-up, they had a 5, and this is a 5.8 years of follow-up. 112 patients in this, and they looked at lots of stuff. They looked at the VAS score, the FAM score, the activities of daily living, and what they found, there was a significant improvement in all these functional scores. The range of movement was also improved. The patient reported outcomes improved as well. And what they specifically asked these patients, what would you have this procedure again? And almost 94% of the people said they would want the procedure again as well. So looks to be a very successful implant. However, I know some in US and part of UK, they have not got this fantastic result. This is from the inventor group, but the other groups have not got such a great results. So we wait to see how Cartiva evolves. And what this group have concluded that was Cartiva remains a viable treatment option to decrease pain, improve the function, and maintain motion for advanced Hallux Rigidus. And that's what they concluded. So we wait and see how this evolves as well. I'm just going to go one or two cases. And this is a very interesting case. And I think it gives a lot of learning as well for people. So this is a middle-aged lady, pain in the great toe, difficulty in wearing shoes. Of course, all these patients have gone through all the conservative treatment. Now, if you look at the x-rays, so this is a weight-bearing AP, an oblique, and a lateral. So these three views are very, very essential views for all the patient, because you can see here how there is a joint space narrowing present, little bit of sclerosis present, a bit of periarticular osteophytes. Clearly here you can see osteophytes present as well. So effectively coming to a grade 2 degenerative changes. So what do you plan? Should you do a cheilectomy? Should you do a cheilectomy or do something else? Should you just offer them a fusion or a replacement? Now, the reason I put the second option, and I want you to people to look at the x-rays carefully, is here the first ray is long. Okay, you compare this with the second metatarsal head, you should be ideally almost at the same level or around 2 to 3 millimeter plus or minus. So you have to understand that the parabola here is maintained or not. So here the patient has a long first metatarsal. So you need to deal with the metatarsal along with the dorsal osteophyte as well. And you can do the lines. I forget the name of the line which you do. So you can draw a line along the first and you draw perpendicular, and it should be almost at the same level or 2 to 3 millimeters. So this is the clinical picture. How you can see clearly a dorsal osteophytes here as well, and that's a skin incision mark. That's your range of movement. Plantar flexion is good, but dorsiflexion is restricted. Good range of movement, but still restricted as well. And you can clearly see when you open it up, there's the joint surface which is damaged here. And on the lateral view, see a large dorsal exophyte or osteophyte present, and that was causing the pain and a bump as well. So this is a saw which is taking off. You start from the joint, literally through the cartilage, and you take it off. All the dorsal osteophytes, slightly more plantar than the dorsal cortex. And finally, you should get is almost a nice surface which is almost parallel to the dorsal cortex of your first metatarsal. Once we have done that, this is the K-wire which has been put through the dorsal, where you have taken the, you have cut the cheilectomy, or you've taken the osteophyte and you plan for a metatarsal osteotomy. And that's where it started here, through that area where you've done the cheilectomy, and you do a shortening osteotomy. Once you've shortened that, and you push slightly plantar and proximally, and you want to get approximately 5 millimeter, 3 to 4 millimeters at least shortening of the metatarsal head. So that's been pushed and you are checking it. So you see the amount of shortening there. That's a dorsal ledge which we will take it out. And that's been fixed initially with just 2 K-wires and check on the radio, check on the C-arm. Once that's done, you can now see how this is come at the level, and that's been fixed with 2 headless screws as well. So this is what you want to achieve. The metatarsal head coming in line with the head of the lesser metatarsals. And that's your final movement. Nice movement, completely free. There you go. Complete dorsiflexion, almost up to 80 to 90 degrees. There you go. There. Okay, so she went on to do very well. So this is another male, 30-year-old male, pain in the great toes for many years, tried all the treatment, and he basically had gout, where the gout, because of the recurrent bouts of gout, the joint was significantly damaged. And again, in the assessment, yes, anybody can say this is grade 4 arthritis, but the key thing in the assessment is see how the first ray is completely short. So he's now loading the second, third, fourth, and will develop lesser metatarsalgia as well. So the key is yes to open it up, but at the same time, look at that. Look at when you get to the length, you need, that is the gap which needs to be filled up. So a tricortical bone graft, here you can see it, was put in. The length was achieved back to its original place and then fixed with a plate. That's the final picture, final union, and he went on to do very well. Thank you so much. Any questions?
Thank you, Pradeep. Excellent presentation as usual. A few questions.
Yeah.
One is the proximal phalanx osteotomy that you mentioned, right?
Yeah.
Is it a name procedure? For example, I heard somewhere it was named as Marburg procedure.
Marburg. Yeah, so there are lots of names. So I didn't want to go into the details because people get confused. So as long as people understand the principle, and that is why the key thing is the assessment in the initial stage. Yes, you can do a Marburg. So Marburg phalanx, you can do a Marburg metatarsal osteotomy. But as long as you understand the principle and your, as I said in the case, that's why I wanted to show that case. In your clinical assessment, you see why the patient has a MTP arthritis. Is it because of something else or is it a mechanical issue? And then you can plan accordingly. And even if you are doing, if just after cheilectomy, you want to change your range of movement, then yes, you can plan a arc of movement like a plantar flexion osteotomy or dorsiflexion osteotomy or whatever.
The other one is, what is the role for a Keller's resection? The resection of the proximal part of the proximal phalanx.
So I don't do it. I think, but as I said before, if you have an elderly patient who really want them to get pain free and get going, you can offer them. But the first ray really gets short. Okay, fantastic pain relief. So if you had like a grade 4, but patient is not able to non-weight bear for 6 weeks, you can offer them these, but not in younger patients. And young patients, I would say up to 60 now.
And regarding the Cartiva implant, it's I was just looking into the data, and it's made of polyvinyl alcohol. Is it available in this part of the world?
So not available in India. So we had a demo, I think last year or last year in an Indian Foot and Ankle conference. They have not released it as of now. They have a license only for US, not even US. I think Canada and UK. UK, talking to a few surgeons, friends of mine, they have not done exceptionally great in UK. But the inventor group says that even if it fails, you have not lost anything. You can always come back and do an fusion surgery. Okay, that's great, especially if the patient is not paying. But in our population, the patient suppose wants only one operation, then you have to be just careful. But it looks promising. I think it looks promising and something to add to your armamentarium as well.
And Pradeep, in your experience in, say, suppose you have done around 25 or 30 cases, what is the most common procedure? I'm sure you've done a lot more, but what is the most common procedure that you have used? Is it an MTP joint fusion?
Yes. So I, even for my Hallux valgus, Hallux varus, I do a lot of fusion because they come at such severe deformities that even if you do the massive, say, release, you do a scarf. When I do a scarf a lot, even then you can't rely completely on them, and they gradually try to drift. So giving them one surgery, one option, MTP fusion. And that is why I kept another almost a separate talk for the MTP fusion. And I think people really need to learn this operation, and they really need to be sleek in that operation, because it's such a satisfying operation for the patient. And invariably, yes, we talk about fusion, but the patient really don't miss a lot on that loss of movement.
And what is the most common implant that you use when you do a MTP fusion? Is it non-locking or a locking plate?
So I started with 2 screws, but I think with the kind of deformities which we have, in spite of all the release, the tissues are tight. So I invariably use 4 mm cancellous, 4 mm partially threaded screw and a locking plate, always. And it's interesting. I have 1 or 2 failures of cases which have severe deformities, and I don't know why they have failed, but I think it's probably because of the inadequate release around these soft tissue around the MTP joint. So you have to be very careful. You have to be massive release around that.
And is it a specifically designed locking plate or a standard 3.5 mm locking plate?
No. There is a specific design MTP fusion plate.
Okay. And the other screw that you mentioned is first you're going to put the interfrag screw and then do the fusion, is it?
Yeah. So what I do is I put 2 wires, one holding wire to make sure that my position is correct, and then another wire which will be my CC screw wire. Then I fire the CC screw. I get the adequate compression which I need, and then put my plate. It's interesting. I was with Mike Coughlin. Mike Coughlin is like the father of the 4-foot. And he, one of the demos which he had come last year, he actually put the plate first and then the CC screw. And everybody was amazed. Why have you done that? Normal orthopedic principles, always put your interfrag screw and then a plate. He did the other way. He put the plate because he got the position perfect, and then he put the screw. And the reason, and I spoke to him personally after that, and he said, even though you're using your screw later on, you may not achieve the compression, because the compression you could achieve through the plate. But this is another stabilizing factor. And that is one of the reasons when I went back and looked at my plates which I failed, I thought I had got enough purchase and enough stabilization through my plate. But if you add another CC screw to prevent or to buttress your deform, so like if you have a Hallux valgus, you make sure you pass 1 more screw which takes away your deforming force that really stabilizes it. So even if I do not get initially, if I do not put a CC screw, in the end I will put a CC screw.
Okay, and all your plates are dorsal, isn't it?
It is always dorsal. And all these are dorsal plates designed by various companies, Indian companies, as well as you have Arthrex, Smith & Nephew, Synthes, everybody has it. And they are 0, 5 and 10. So standard 10 degree, you can use it. And this is another thing which I learned from Mike Coughlin as well. A standard 10 degree, it will give you the standard position. So you may not even check the plate test which I showed you, but that's a little bit overconfident, I would say. I always put the plate, stabilize it with two threaded pins, and check with the plate. And that's a double test.
Yeah, the plate test is, I mean, it's a very wonderful way of demonstrating. All you need to see is the tip of the toe should be slightly off, isn't it?
No, so it's quite interesting. If you read it, it can touch it, but you should be able to dorsiflex and come back again. If it is too off, then what will happen is the patient try to, because when you're walking, you really need that tip to be on the floor. So the patient will try to then do an IP joint flexion, and he may not have it if he doesn't have enough power on FHL. So it just touches it, actually touches it, but you should be able to take it off and then put it back again.
So the ideal position is 10 to 15 degrees dorsiflexion, isn't it?
Yeah, so 10 to 15 degrees dorsiflexion of the plantar surface or 25 degrees of the metatarsal. Now it is very difficult to judge. So that's why the plate test and remember this, though it is at 10-15 degrees dorsiflexion here, there is still this movement. So when you're putting it here, it should still be touching like that. You see that? Yeah, I think. So that's
Yes, clear.
so don't bother about numbers. That's what, so finally, that's what I've learned with Mike. Don't bother with numbers, get that, because finally what you want, patient walking should be happy.
And just because you have mentioned Dr. Coughlin's name, the classification is also named after him, isn't it?
Yes,
Hallux
Coughlin
Rigidus.
and something.
Man and Coughlin, is
Yeah,
it?
Coughlin and Strauss or something like that, yes.
The other last question before you wind up the session is, have you tried MTP joint arthroscopy? Have you started doing it in India?
I have not done it. I've heard I'll tell you, and Holly from US talking about it when I was there in 2 years back. Very specific indication, especially you're looking at a early hallux rigidus where you looking in the joint and trying to do a microfracture or a loose body in the MTP joint, or diagnosing a volar plate and you want to do something. We don't get that kind of patients in our practice. So yes, you could do it. You would really need a 1.1 or 1.2 mm or 1.8 mm scope, and you can do it, but I have not done it. And that kind of even patients of cheilectomy is quite uncommon in our practice.
And Pradeep, just before we conclude, see, we discussed about arthritis, and even in foot and ankle, we have seen osteochondritis dissecans there, isn't it? Cartilage defects.
Yes.
What do you think that? Do you think that hallux rigidus is a, I mean, endpoint of an early osteochondritis dissecans involving the MTP joint?
So again, you can say wherever, whatever. So that's why one of the if you look, the etiology was significant trauma and mild trauma. And mild trauma could be repetitive injury. And again, patients who have gout attack, every time a crystals form, there is a damage to the joint. Or you could have a single episode of a twisting, patient forgets about it, and you could have an osteochondral lesion. So that was one of the etiologies. Problem is patient don't remember that anytime they had any injury. If we get a sportsman who have that specific injury and they come back, then yes, a role with MRI scan and MTP arthroscopy would really be good, because once you open up with that big an incision, you end up slightly stiffer anyway. So you would not be able to get the maximum benefit for these small group of people. So yes, osteochondral lesion can be there. You can pick it up on MRI scans. And yes, if you were really good in arthroscopy, you could probably deal with them as well.
Okay, Pradeep, I think that's all the questions that we have. Thank you for yet another fantastic session. And it's been very, very enlightening for all of us. And we really look forward for another lecture whenever you have time later on.
Thank you. Thank you so much, Hitesh, for having me around. Thank you.